Very good evening, everyone. My name is Devani Pandey. I am from the marketing team of Sun Pharma. Today, I would like to welcome you all in our Diabetes Prime series, where we are going to host an interactive session on gliptins. The topic will be all-round intensification in diabetes management. To take us through today's topic, we have our renowned endocrinologist from Mumbai with us. His name is Dr. Madhur Ji Maheshwari. Doctor is MD, DNB Endocrinology, and he practices total health clinic in Andheri West in Mumbai. So, with this brief introduction, I would just like to hand over a session to Doctor. So, please go ahead, sir. We all are looking forward to hear from you on this particular topic.
Yeah, thank you. Thank you so much. So, good evening, everyone. Today we'll be discussing the topic. The name of the topic is all-round intensification of glycemic and non-glycemic benefits in patients with diabetes. So, we'll be discussing how to intensify diabetes treatment approach with combination therapy. What do the recommendations and the guidelines suggest? We have a novel triple drug combination available, which is sitagliptin, metformin, dapagliflozin, and how this combination therapy is effective in diabetes management. So we all know that the burden of type 2 diabetes is rising in the country. And despite all the new therapies, the control in our patients continues to remain poor. So as per the latest ICMR study, the HbA1c in our patients is about 8.2, and hardly 30% of patients achieve their target A1c. And this poor control eventually leads to cardiovascular diseases, CKD. Almost 88% of our patients are overweight or obese. 42% have metabolic syndrome, and almost 5 to 37% patients suffer from micro and macrovascular complications. So we all know that cardiovascular disease is the most common cause of death and mortality in type 2 diabetes patients. It increases almost twofold, and there's almost an 8-fold rise in the risk of heart failure. Diabetes is the leading cause of kidney disease as well, and glycemic control and blood pressure control is extremely important. We've all seen in our practice that our patients count the number of pills that you're writing. They're very happy with the minimum possible treatment, and studies have shown that compliance is much, much better with the combination therapy. So hence, the combination therapy can help in improving compliance in our patients. And is it efficacious? So this is the conventional way type 2 diabetes is managed by most doctors in the country. They would start with lifestyle measures, which would show transient improvement, after which the HbA1c would start rising. Then the doctor would add one OAD. There's a lot of inertia in adding an up-titrating medication. And each time the patient becomes uncontrolled, patient would swing from control to poor control. And this would eventually lead to complications later with type 2 diabetes. If we initiate combination therapy early in treatment, the control is much better and sustained. So this would eventually lead to fewer complications. So an early and more aggressive intervention approach provides more rapid glycemic control and therefore improves patients' glycemic profiles without significantly increasing the risk of side effects. So we all are aware about the UK PDS study, which showed the legacy effect with the initial control in the intensive arm compared to the conventional treatment arm, which had an HbA1c of 8. So what do the recommendations say? Most of the leading endocrinology guidelines, societies, bodies endorse combination therapy use. It may be dual or triple drug combination if the HbA1c is above 9. Even the ADA has a similar position when it comes to combination therapy. So combination therapy can increase the durability of glycemic effect, the potential impact on medication adherence and treatment persistence, complementary clinical benefits is observed, and these individual therapies address synergistic pathways, hence leading to better control. Even the RSSDI guidelines endorse use of 2 or 3 agents if the control is more than 1.5% above our target. In elderly patients with increased risk of hypoglycemia, we could consider DPP-4 inhibitors as an alternative to sulfonylureas. So triple drug FDC therapy, how can we use it to intensify therapy? So the benefits are clearly there because it addresses multiple pathophysiological targets, reduce pill burden, improve compliance, better glycemic control. So if we look at the conventional, the old triple drug combination, which was with metformin, sulfonylurea, thiazolidinediones, had the problem of weight gain and hypoglycemia. This triple drug combination with metformin, now we have a combination with sulfonylurea and an SGLT2 inhibitor, can address this weight loss, weight gain aspect with thiazolidinediones. In the Asian population, it has been noticed that the gliptins fared much better. The effectiveness was much more compared to the Western counterparts. So we all know that metformin is the first line agent, but adding the second or the third line agent would increase the achievement of HbA1c targets. It has proven CV safety, proven kidney safety, and low risk of hypoglycemia and weight loss. Very important in the management these days. So control is more rapid and sustained. There's extra glycemic benefit in the form of weight loss and better blood pressure control. It improves insulin resistance and beta cell function. There's reduced pill burden and hence can be cost effective as well. So we're all aware of the omnious octate, different pathophysiological pathways that eventually lead to type 2 diabetes. Metformin, sitagliptin, dapagliflozin address most of these defects by a direct or indirect action, thus leading to better glucose control, fasting and postprandial, better HbA1c control, better glycemic variability, and more time in range, and better quality of life. So we're all aware that the combination would lead to better fasting plasma glucose, postprandial glucose, and HbA1c compared to the conventional treating or placebos in trials. So the triple drug combination has gone through double-blind trials, which include almost 400 patients who were randomized to receive placebo or combination. And obviously, the combination arm fared better when it came to HbA1c control. In fact, this group also achieved weight loss, about mild to moderate weight loss compared to placebo. So this was another study which looked at the combination versus the triple drug combination versus the sitagliptin metformin and dapagliflozin metformin dual combination. So obviously the HbA1c targets were HbA1c was better in the triple drug combination arm versus the dual treatment arms. The fasting and the postprandial glucose was better reduced. There was weight loss noticed, and more patients achieved their target HbA1c of less than 7 at 16 weeks. Are there benefits beyond just glucose control? Obviously, we know that there's robust glycemic control, HbA1c reduction to the tune of 2%. It has cardiac and renal benefit as well, so addresses the comorbidities. Weight loss and non-occurrence of hypoglycemia with this combination boosts the patient's morale, and there's obviously improved compliance with a single pill. We're all aware of the DECLARE-TME trial, which showed cardiac benefit and especially reduction in hospitalization due to heart failure. And this was further studied at the DAPA-HF trial, which showed that the worsening heart failure component was significantly better in the dapagliflozin arm, and it reduced the hospitalization due to heart failure. The DAPA-CKD was done to look at the renal parameters, and they looked at 50% EGFR reduction or end-stage renal disease or renal or CV death, and there's almost a 40% relative risk reduction in the dapagliflozin arm compared to placebo. The TCOS trial showed that it is cardiac safe, allaying the initial concerns with which was shown with saxagliptin. So the clinical evidence from safety standpoint, the study showed that the adverse events were significantly lower compared to the placebo arm. So, and the risk of AGL, infections, especially UTI infections, the possibility of lower urinary tract infections, and was noticed with the combination. We do not know why, but this has come as a revelation where combination of SGLT2 inhibitors and DPP4 inhibitors somehow reduce the chances of genitourinary tract infections compared to SGLT2 inhibitors alone. SGLT2 inhibitors do not cause hepatotoxicity. No dose adjustment is required in mild to moderate liver dysfunction. So, there's effective glycemic control, weight loss, blood pressure control, lower genital infections, renal safety is there, addresses most of the pathophysiological defects, offers CV protection. So it is near an ideal diabetes pill. So identifying patient profiles who could benefit from this triple drug combination. So if the patient is uncontrolled with metformin and a second line glycemic glucose lowering agent, one could consider this triple drug combination and try and achieve the better glycemic target. In obese patients, this could be a good option. Obviously, GLP-1s are much more superior when it comes to weight loss, but not pocket friendly. So the combination can be preferred over other conventional treatment arms to promote weight loss in obese individuals with no risk of hypoglycemia. So it can be used for CV safety, have shown favorable CV safety with no increased risk of heart failure hospitalizations with sitagliptin, and dapagliflozin has shown cardiac benefit. So this combination should be preferred over conventional therapies in patients with cardiovascular disease with or without heart failure. In CKD as well, sitagliptin needs dose adjustments below an EGFR of 30, but can be safely used in higher EGFRs. And dapagliflozin has been studied up to EGFR of 20. So we could use this triple drug combination for all-round intensification in our type 2 diabetes patients. Thank you for your patience. Thank you.
Thank you so much, sir, for your insights on a particular topic. So I can see there are 2-3 questions present over the chat box. So first question is, if there is any cases of pyelonephritis as associated with the SGLT2 inhibitors?
So obviously in patients who have active UTI or multiple episodes of urinary tract infections in the past, SGLT2 inhibitors are best to be avoided. So this is something to be cautious about, especially in women. You can counsel them on genital hygiene, but I would avoid it in patients who has frequent UTIs or pyelonephritis history in the past.
And the second question is, can we offer this combination? Mainly, this is for, I think, for the women's, the one who is planning for the pregnancy. This particular
no, we cannot use this. We cannot use this in patients who are planning pregnancy.
Okay. And the other question is there any side effects associated with the gliptins? So if yes,
Gliptins are
Mhm. If
gliptins
yes, is
are
there an,
like, go
if
ahead,
there
ma'am.
so if there are any side effects associated with the gliptins, so in comparison to which is the better gliptin to offer, linagliptin or sitagliptin?
Look, most of the gliptins are safe, relatively well tolerated, hardly any side effects, so convenient option to add when the HbA1c target is not met. Uh, the second question, the second part is which gliptin is better. I would say sitagliptin, linagliptin are equally, efficacious. Vildagliptin and the teneligliptin, I would say, are relatively less potent compared to sitagliptin and linagliptin. This is my personal experience.
Okay, so thank you so much. I could only see the three questions were there, and I hope we all get benefited from the insights shared by you. So again, thank you so much, everyone, for the patient listening, and thank you so much again. Have
Thank
a
you.
good evening.